Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Welcome again, everyone, to today's program, The State of Oncology Now, with Dr. Cheryl Jones and Dr. Cantuaria. I am Katie Armsby. I'm the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we welcome you. We invite you to visit our website, cscatlanta.org, so you can see all the virtual and in-person programming that we offer. We do continue to offer a lot of our programs virtually, but we are kind of incorporating more in-person programs. So we would love it if you could come check us out. We're off of Johnson Ferry Road in that Center Point building. We have some great support group rooms, a demonstration kitchen, and a yoga studio as well. So I do want to share, we do have support groups led by licensed mental health professionals. Some of those are diagnosis specific. Some of those are more general. We also offer a caregiver support group. We do have great stress reduction classes. Yoga and Tai Chi are some of them. We offer a monthly nutrition seminar facilitated by an oncology dietitian with Northside Hospital Cancer Institute. And we do have one coming up next week that focuses on breast cancer and nutrition. And I will put that registration link into the program chat box. We'd love it if you could join us, and that's in person and virtual. And we also have education programs like these. So for a complete list of all of our programs, all of our free oncology support programs, please visit our website, cscatlanta.org. And we'd love it if you could connect with us through our newsletter as well. So we ask that you register for programs through the website as well. And we do also have a video link. So if you ever miss a live program, you can find a recording on our website too. So if you know anybody who couldn't join today's event, we'll have it up on there as well. So like I said, everyone will remain on mute for the duration of today's program, but we do invite you to enter questions into that program chat box, which will be addressed at the end of the program during the Q&A. I'm excited that we were able to partner with Georgia Core for today's program and to introduce Lynn Durham, the president and CEO of Georgia Core, to share a little bit about them as well. So Lynn, I'll pass it off to you.
Great, Katie. Thank you so much. I appreciate it. And I appreciate having the opportunity for Georgia Core to partner with Cancer Support Community. Katie will tell you I am one of their biggest fans. I'm a cancer survivor myself and think they do amazing work. So I'm very grateful for them. If you could go to the next slide, please, Katie. Georgia Core is a nonprofit. We're a statewide nonprofit. We work throughout Georgia to advance cancer research and improve cancer care throughout the state. And so our three pillars are education and research and advocacy. So we work in different areas. We were formed nearly 20 years ago. We're having our 20th anniversary next year, where we were formed to bring more cancer research and more clinical trials to Georgia. So we still work very much in that area, but we have broadened to all areas of cancer to make sure we provide support and resources mainly for survivors, for cancer patient navigators, for caregivers, for physicians, and others. And so if you would visit georgiacancerinfo.org, that is our website, and we provide a huge amount of resources there for people going through cancer or interested in any topics surrounding cancer. So we thank you so much for being here, and I'm very pleased today to introduce Dr. Cheryl Jones. Dr. Jones actually just joined us a few weeks ago. Georgia Core and GASCO hosted a disparity summit in cancer clinical trials, and she was very kind to be part of that. Dr. Jones is a board certified in internal medicine and in medical oncology, and she did her research and fellowship at the Medical College of Virginia. And she doesn't know this, I was actually born at MCV many years ago, and so that's a great connection. She works down in Macon, and she is the president of the Georgia Cancer Specialist and works in their Macon location, and has been very involved throughout the state in different medical organizations. And I won't list them all, I'm sure she won't mind, but she's incredibly engaged in the cancer community in Georgia. So Dr. Jones, I'd like to give it over to you.
Thank you so much, Lynn. And anybody wants more information about Georgia Core, they can learn it at georgiacancerinfo.org. So a lot of good resources there. I now have the privilege of not delay this program anymore, but move on with the introduction to Dr. Cantuaria. He's the chairman of the Northside Hospital Cancer Institute, and he's among the most distinguished and experienced robotic GYN oncologists and surgeons in the country. Over the years, he has lectured both nationally, internationally. He's published multiple authors and on the subject of GYN oncology. In addition to being committed to providing excellent medical care to his patients, he's an active participant in clinical research and is a strong advocate for the individual cancer care. And with no further ado, I'm going to turn it over to Dr. Cantuaria.
First, thank you for the invitation. I am another big fan of the cancer support community, and I'm also a very big fan of Georgia Core. What Georgia Core has done for clinical trials throughout the state of Georgia is huge. I mean, they're a partner of Georgia NCORE, which is an NCI grant, a multi-million NCI grant that's held by Northside Hospital, and they are main partner of that coalition to really bring more institutions and hospital systems into the program to increase clinical trial exposure and enrollment throughout the state. So what Lynn has done is phenomenal, and she's very active in that. And all I can do is thank her and Katie for the great organizations that they run. So thank you for the invitation. I've been asked to talk about this State of Oncology 2022. It's a very broad topic. I'm not even sure why I would accept something so broad. But anyway, I'll try to do my best to try and hopefully capture what's going on nationally or internationally in regards to oncology. I'm going to review what I think are the breakthroughs and where we stand in oncology as general. As a background, I'm a GYN oncologist, so I deal with women's cancer in general. And thank God we've got Cheryl Jones over here, which is a medical oncologist, a lot smarter than I am, that can deal with questions that come from all the other cancers that may arise within this discussion. So what we've seen lately, and this has made headlines throughout news channels and throughout social media, is really that we have seen a decrease in the risk of dying of cancer throughout these years. And this is what has happened, and we have seen a drop in 1% in the 90s, and now we're seeing a drop of 2% a year. And more recently, I'd say since 2015 more specifically. And these trends are real, and they have to do with several factors. Being the main one is the drop in lung cancer, that being less people smoke, thank God. And also improved screening and detection of early cancer. So we've gotten better in prevention and screening modalities, and also in the treatment modalities. I think the huge breakthroughs with immunotherapy with very specific cancers out there have made dramatic differences in the risk of death, specifically, for example, melanoma, advanced stage melanoma. So I think in general, we have seen a positive trend, and it's a real trend, and we are doing better as the years go by. But it's still a significant problem. It's the second most common cause of death in the US after heart disease, 1.9 million new cancer cases a year, and 609,000 deaths from cancer a year. And it's, if you really think about it, we probably shouldn't be getting this disease at all. We should be in a situation that this disease actually doesn't exist or is a rare disease, from a logic standpoint, at least to me. Right now, the lifetime probability of developing cancer for a male is 1 in 2. Statistically, we're going back and forth now. Are people seeing what I'm seeing?
Yeah.
I was just gonna share the slides. James said that it was Zoom was being weird on your end.
So you want to do it for me? That's fine. Just do it for me then. Next slide.
Okay.
So the lifetime risk of a male developing cancer is 1 and 2. Basically, a baby boy just gets born. He has a 40.2% chance of developing cancer in his lifetime. A baby girl gets born. She has a 39% chance of developing cancer. And the most common cancer in males would be the prostate cancer. Not surprisingly, next slide is breast for women. 1 in every 8 women will develop breast cancer in their lifetime. So this still remains a huge problem and that we have to tackle. Next slide, please. And especially because many of these cancers are avoidable, potentially avoidable. I would say that at least, and this is a very, very generous, I think, underestimation, in my opinion, that 42% of new cancers are potentially avoidable. It's probably more than that. I'd say probably a lot more than that. 19% of cancers are caused by smoking, 18% are combined obesity, so it's what you put in your mouth really makes a difference, alcohol, poor nutrition, and inactivity, physical inactivity. So all these things contribute to people developing cancer. Then we have cancers that are potentially preventable from viruses such as HPV, which can cause a number of different cancers in males and females, including cervical cancer, vaginal cancer, vulvar cancer, anal cancer, head and neck cancer, and the list goes on. So a lot can be done from a national level, I think, for us to get better, not only from the treatment, but also to decrease the number of cancers that develop in the nation. So next slide, please. When I was asked to put this talk together, I thought, what would be in my opinion, the biggest things that have happened lately and continue to occur in cancer in general? And I came up with these 6, and other people may have different ideas, and maybe Cheryl has others that she thinks should have made this list, but I came up with genetic testing, repurposing of drugs to fight cancer, repurposing we'll explain later, targeted immunotherapies, targeted therapies in general, and increasing diversity in clinical trials and artificial intelligence in the management of disease in general. And we'll go through each one of these in a little bit more detail. Next slide, please. Next slide, please. So genetic testing may be a bit confusing for some folks because we do it in 2 main areas. We look at the germline testing. This is what the patient has inherited. So what are her genes telling us? And we do it in somatic testing, and that's what the tumor is telling us. And they're 2 different things, completely 2 different things. And the problem I personally see is not genetic testing as being a breakthrough, because since the genome has been completely mapped out, and that was in 2003, we've learned a tremendous amount of things related to cancer and genetics. An unbelievable amount of information has come from that mapping of the gene. But it's not what we've discovered that's the problem or the breakthrough. The breakthrough is fixing this lack of genetic testing that we have going on. This is available currently, and germline testing, which is testing for these hereditary cancers, is available. And many cancers, it's probably breach of standard of care not to have it done, for example, in ovarian cancer. And hundreds of thousands of people at high risk of developing cancer currently don't know that because they've not been tested. And we have to fix that problem. And tens of thousands of folks with currently that have cancer have not had their tumors tested for this genomic profile that would allow them to get the latest or the standard of care targeted therapies. So even that's being underperformed in both areas, and we have to address this at the local, regional, and national level. A lot of this, I mean, Georgia Core has been instrumental in education to really get the word out there about genetic testing. So I have to thank Georgia Core for that, and actually the cancer support community too. Northside Hospital has a tremendous team of genetic specialists and counselors. And we're very fortunate. It's not common to have a community hospital with so many genetic counselors and being able to offer this to all our cancer patients. So we're very fortunate here at Northside to have that team. Academic centers have those, but not every community center has that. And to overcome that problem of not having genetic counselors at the community setting, especially in the rural areas, there are many programs, or national programs that, and actually this is what we call a type of trial called a CCZR trial. And it's really bringing genetic counseling or other forms of delivery of cancer care to areas which don't have the financial ability to have that, or the professionals to be able to deliver that care. And through the Georgia NCORE and Georgia CORE, there are trials which allow patients to enroll for genetic counseling centrally if they don't have it locally. So these are things that maybe patients can ask their community or their cancer centers or their providers if they have the ability to be plugged into something like that. Next slide, please. Another topic that I think is extremely interesting, and unfortunately, another area that has not been given the appropriate funding and exposure is repurposing of drugs to fight cancer. Repurposing means that these are drugs that have been used for something completely different. And that's the good thing about them. That means they right now have lost their patent, which means they're extremely cheap compared to cancer drugs. They're extremely safe. We've got decades and decades of experience giving these drugs. We know their side effects. We've mastered this. So they're extremely safe, different from new drugs that come on the market, which we still have to learn their toxicity profile, and they're completely new toxicity profiles. This is not the case with repurposed drugs. And they are readily combined with other treatments. A problem with cancer care today is these new treatments that we pile on top of each other. Immunotherapy, then we have targeted therapy with the tyrosine kinase inhibitor. When we start piling these new drugs, we don't really understand and know fully how toxic these drugs, these new combinations can be. Many of these new drugs cannot be combined. Different from repurposed drugs, which are for hypertension, diabetes. We've been giving these drugs with the current chemotherapy agents, radiation therapy, and immunotherapy because they're part of their medical history and their current medications. So they can be readily combined with all these cancer treatments, most of them, with minimum addition of side effect profile. And so for reasons that are mainly related to financial reasons, I think these drugs have not been given their fair share of being studied and being available to patients. If they lose the patent, drug companies can't make money on these drugs, and the clinical trials are expensive to be done. So somehow this has to be addressed at a state and a national level. For example, if you really think about how repurposed drugs and how successful it can be, one can just look at Viagra. Viagra is a drug that has been repurposed 3 times. It was initially used for hypertension, repurposed for angina, and then throughout these clinical trials with these drugs, male participants would find out of an interesting side effect that would address a sexual problem. And certainly this drug is now a very successful drug out there. So repurposing these drugs can be very successful. And I listed 3, and there are probably a lot more, but these are 3 very interesting ones. For example, patients with diabetes, they already have a higher chance, a worse prognosis if they develop cancer. That's a known fact. For whatever reason, diabetic patients, just by being diabetic, do worse than non-diabetic patients that have cancer. But a subgroup of those patients, ones that take metformin, actually do better than non-diabetic patients, which is very interesting. So not only do they do better with other diabetic patients that don't take metformin, they actually do better than non-diabetic patients, which are supposed to do better because they don't have diabetes as a whole. So that finding has been a common finding throughout the world, which has brought this drug into the forefront to try and understand how in the world this drug works from an anti-cancer standpoint. Not only does it prevent cancer, it can treat cancer. We think it can prevent cancer and treat cancer, but we haven't gotten to the bottom of this. Trials have been non-conclusive in several of the trials with metformin, but it's something that's very, very interesting to see from a statistical analysis of population, how this drug has worked. And when we have population studies and we notice these differences, there's so many variables. That's why we need the clinical trials. The variables that we may think is metformin is doing the trick, but it's actually not. So these clinical trials have to be put together and explored. Propranolol is a hypertension drug, and it has been noticed to work in pancreatic cancer and angiosarcoma, which is a rare disease, rare cancer. And we don't understand that fully. That needs to be studied further. Aspirin, by being an anti-inflammatory, has been extremely interesting to notice the findings, specifically in colon cancer, of how it can not only prevent colon cancer in patients with high risk of getting the disease, like Lynch syndrome is a hereditary form of colon cancer. Patients that are on aspirin versus placebo have a dramatic difference of incidence of colon cancer, decreased colon cancer, than patients that were on placebo. And it not only works on the hereditary forms of colon cancer, but also works in colon cancer in the general population that don't carry the mutated gene that predispose them to get colon cancer. So this has to be explored. By decreasing inflammation in general, just as logic that you would have a less chance of having cancer, which is inflammation in general can increase chances of getting cancer as a whole. Next slide, please. So moving topics, targeted therapy is a big topic because there's several things that come into play with targeted therapy. And next slide. But here, go back one slide, because I actually separated these. So targeted therapy is you look at the genome, and we'll get back to that, one of the breakthroughs that I think have been in cancer, which are genetic testing, which we'll talk later. But targeted therapy, essentially in a nutshell, is you identify a target gene or a mutated gene or a protein, and you find a very specific drug that will act on that mutation in the cancer cell, which means potentially this drug will just act on those diseased cancer cells and spare the normal cells from the toxicity. And it could be, and we have several of these drugs today that are targeted, and we're discovering them by the bunches as the research continues, because we're finding more and more mutations and more actionable drugs for these mutations. And this has been one of the greatest breakthroughs, I think, in cancer care in general. Next one. And more specific also on the side of targeted therapy, we can just look at targeted therapy in immunotherapy. Immunotherapy, quite frankly, is already, it can be a general or it can be targeted. So when I mention targeted immunotherapy, it can go from identifying just a biomarker that would make that patient more prone to respond to immunotherapies in general. And when we talk about immune therapy, there are many forms of immune therapy, but most of the time it's in a general way, is what we do with immune therapy is we enhance the immune system to target, to work better. Cancer in general finds a way to evade the immune system by many mechanisms. It's not part of our body, it's a different cell, it's a completely aberrant cell. And still everything that's not part of is not part of our body, it's aberrant at that level, should be destroyed by our immune system. That's how viruses get destroyed, that's how bacteria get destroyed, and that's how cancer cells get destroyed on a regular basis on all of us on a daily basis. But somehow when cancer develops, it starts creating mechanisms to evade the immune system. And what immune therapy does in general is enhance our immune system to be able to, it's taking the brakes off the immune system, putting the, the pedal to the metal to make the immune system more robust and to be able to attack the cancer. And we have specific biomarkers today that we can measure on patients. There are several out there that will tell which patients are more likely to respond to immunotherapy while others are less likely to do so. And and CAR T cell, that's a very, it's complicated but effective way to, an intelligent way to specifically perform a targeted immune response to treatment. So what is that? What it does is we remove T cells, which are part of our immune system, from the patient, and we genetically modify these. And what the CAR means is chimeric antigen receptor. What we do is we put a receptor on the T cell that's specific to a specific antigen. Antigen is a protein that is specific to the cancer that that patient has, which means now we multiply these T cells in a dish in the lab, and then we get this army of genetically modified T cells, and we reintroduce these T cells into the patient IV, intravenously. And these T cells are now programmed to specifically target the cancer cells. It has been a huge breakthrough in cancers of the blood, in hematologic malignancies, and it's now being studied in solid tumors. Immune checkpoint inhibitors is essentially what I mentioned about taking the brakes off the immune system and enhancing the response. And there's several ways to do that. And it has made dramatic and impressive changes on very poorly, on very poor prognostic cancers like metastatic melanoma, and changed completely the chances of these patients surviving their disease. And it's not only for melanoma. Today we use immune therapy a number of it's standard of care in a number of solid tumors, and in some tumors that the response is so dramatic if they have that biomarker, specifically in rectal cancer, colon cancer, we can have complete responses of the tumor, which means there's no evidence of disease from a surgical standpoint. I'm talking about pathological cure, which patients which have colon cancer, for example, which are treated typically with surgery, chemo, radiation. And now we have studies showing that if we give immunotherapy to these patients before their surgery, when we go do the surgery and take the portion of the colon that didn't have the disease, up to 60, 70% of those patients, we can't even have the disease. We don't even see the disease in that site anymore. And that's so impressive, because what it tells us is that there will be a time that we will not be needing to do as many surgeries as we did before for cancer, that we can get rid of this without the typical aggressive, potentially morbid surgeries that we do many times for cancer. So that's very exciting. Monoclonal antibodies. This is a way that we use in immunotherapy to create what we call antibody drug conjugates. We develop an antibody to specific antigen, similar to what we discussed a little bit earlier. And there are certain antigens out there, markers on cancer, that are very specific to that specific tumor. I can, for example, I'll give an example of cervical cancer, this tissue factor. It's a antigen that's overexpressed in cervical cancer patients. And if you develop an antibody to tissue factor, you could potentially just target the cervical cancer and avoid the antibody going elsewhere. Because when I say overexpressed, it's because these antigens are expressed many-fold, thousand-folds, sometimes million times fold in the cancer cell versus a normal cell. So it would be very targeted treatment to the cancer. And what we do with the antibody just going is not the issue, but the antibody goes with a payload. We attach very high doses of chemotherapy to the antibody that we could not give if we just deliver the chemotherapy IV wise. It would be extremely toxic, but we can deliver that payload just to the cancer with minimum toxicity because the payload is only going to the cancer cell. And once the antibody attaches to the cancer cell surface, it gets incorporated into the cell. It invaginates, incorporated into the cell. The payload is released inside the cell, and that way it becomes a targeted agent and the cell dies. So there are many antibody drug conjugates currently approved. We have one already for cervical cancer. We have one coming up for ovarian cancer, which is related to another marker, which is called the folate receptor, which is overexpressed in ovarian cancer. And many other solid tumors have the same type of overexpression of certain antigens that would have their specific antibody drug conjugate available for them. And I'm sure Cheryl will be able to share some of those later on if you all have questions regarding that. And obviously vaccines not only for treatment, it's vaccines from prevention standpoint are very, very important, and those are being developed currently. So we're making huge advances in immunotherapy in general, to the point that I think if you look at over the decade, the biggest breakthrough in the last decade, I'd say immunotherapy by far is the #1 change in the way we deal with cancer over the last decade. Next slide, please. Targeted therapy that I mentioned earlier, next slide, really has to do with getting now very specific information about that tumor. What is the mutations that this tumor has that allows us to create a targeted agent to deliver cancer specifically to that cancer cell and sparing the normal cells around that. And we do that by doing biopsies of the tumor. That's the typical standard of care way of doing to develop these tests. But over the last couple of years, liquid biopsies. Now we're identifying now as the cancer cell dies and also even lives, it releases its defective DNA. And this defective mutated DNA can be picked up not only now on a directed biopsy to the tumor, but also by picking up these circulating pieces of DNA or cells, even cancer cells circulating, that we can now measure in the lab the mutations and we can use this information not only to identify targeted treatments, but also to see if the treatment is working, because as circulating tumor DNA and circulating tumor cells decrease in the blood, we have a direct measurement, if you can say that, of how the response is, so we can get prognosis information from, and not only treatment information from these biopsies today. And we can personalize the treatment quite well. It can be used from a screening standpoint, and it can be also, so there's a lot that can be gathered by getting the information from the genomic information from the tumor itself through biopsies, or from what we call liquid biopsies, which are blood tests, which are lot less invasive. Many times patients have tumors grow in areas which we cannot reach with a needle safely, and we just have to monitor those patients with scans. And today we can potentially, in the near future, also have liquid biopsies for the same information for all cancers that we were obtaining in the past from direct biopsies of the tumor. Next slide. Another thing I'd like to wrap up the talk is really diversity in clinical trials. Historically, we have done so poorly on this, and that this, thank God, over the last few years has been a priority of the NCI a priority of all of us that deal with cancer, and is really to increase the diversity in clinical trials. And why is that important? Next slide. Medications that we give to patients. Okay, a little bit of a seizure here, but here we're back to the presentation slide. Medications that we give patients, they affect different races and differently, and we have to be very mindful of that, not only from a toxicity standpoint, but also effectiveness of the treatment standpoint. And we know that for a fact today. So if we don't include the different races, different ages in clinical trials, we end up not getting the whole information, treatment results, the outcomes of these trials, the conclusions of these trials will not be representative of the patient population that we treat in the office. And what we give to a Caucasian, European Caucasian patient very well may not have the same effect in an African-American population. So these diverse populations have different risk factors for developing the cancer too, and that we have to be mindful of that from a screening standpoint. The effectiveness of treatments changes dramatically, and yet till today, and we're changing this as we go, and most patients enrolled on clinical trials are primarily white patients. We, through the core and through Georgia NCORE, have made it a priority to increase diversity in clinical trials. We recently had an abstract presented at a national meeting showing that our diverse population, my minority population, not only from a race population, but also financial diversity, because obviously patients that are underserved and underrepresented are patients also that have no insurance, and we have to be mindful of that. 20% of our patients were on trials that were offered through the Georgia NCORE were of minority based. So we've made huge strides, a lot better than what is done nationally at, just here in the state of Georgia, and we have to congratulate ourselves on that. Next slide. Here you have an idea just of what I mean about racial disparity in cancer care. These are the 5-year survivals by race. You can see that every single cancer on this screen is the 5-year survival or worse in Black population and white population. And that has to do not only about access to care, but also about the genetic making of the different races, of how they react to the different drugs. And sometimes the cancers are actually different. I think even from a histological standpoint, they're different. A triple negative breast cancer, Black patient, a patient with triple negative breast cancer may not have the same triple negative breast cancer of a white patient. And even though they're both triple negative, and the way they react to the drugs is different, and also that triple negativity is not telling many times the whole story about that triple negative cell. So we have to do more studies on this and come with a better solution to overcome this this disparity in cancer care. The next slide. So lastly, actually, I thought the other one was last, but I brought artificial intelligence, and I want you all as from patients to understand what we're going through. We are going through a mammoth transformation in cancer care, an unprecedented transformation in cancer care, something that the pace of change is unmanageable from a physician standpoint. Just to give you all an idea, 64 interventions focused on cancer diagnosis and treatment were approved and had their indications expanded just in a single year of 2020. And that is 2020. 2021 was more than 64. 2022 is probably going to be more than 2021. And the pace of this is unmanageable many times from a human standpoint to just keep up. So we're going to have to do something about this. We can't read papers every second of the day because we've got to treat patients. And that's the level of change that we're getting. I'm sure Cheryl Jones does the same. I study every single darn day. I want to know which other profession, a business person, a consultant, attorney, studies every single day of the year, 365 days a year. None do. But that's what doctors have to do to keep up with the pace of change that we're going through. And still we can't keep up with the pace. So artificial intelligence is an emerging tool to try and help us not only personalize the care, but help doctors guide us through the different scenarios that are going to come up with the different genetic modifications that these cancers are coming up with and that we're discovering, and the multitude of new drugs that are coming on the market for those specific targeted agents that are going to be specific for a specific patient. So all that is, we're going to need tools to deal with that, from not only from a screening standpoint, but also from a treatment standpoint, to come to help patients and doctors navigate the system over the next 10 years. And artificial intelligence right now is a lot better than doctors in many areas, by the way. Oh gosh, I'll be probably, Cheryl, you can't tell anybody I said this on this over here, okay? That if you really look at the papers that are coming out from a radiology standpoint, many papers are showing that there are less mistakes made by artificial intelligence than by a radiologist. And we have to be mindful of that. So we've got to combine these two. We can't just rely on radiologists. And that happens not only from an imaging standpoint, anything that has to do with images, artificial intelligence seems to be doing better. So radiologist, pure image, it'll learn. And pathology the same way. You can't say this, Cheryl, if I said to the pathologist, because I love them to death. But artificial intelligence is learning how to read these pathology slides as good, sometimes better than pathology, and making less mistakes. So we have to incorporate this and be humble enough to accept that. And even from a standpoint of prediction of cancer in the future, it's starting to be able to predict 5-year future, 5 years in advance, the chance of a patient developing breast cancer on a normal mammogram. So a normal mammogram doesn't mean the patient won't develop breast cancer. It means she doesn't have it right then. But these things are able to gain, to project the future, things that we can't do just by reading the mammogram today. So we're going to have to find where to incorporate artificial intelligence in our day-to-day lives. Be humble enough to accept that we as human beings do have deficiencies, and that we do make mistakes, and that we can get better by incorporating artificial intelligence in our care. I have to stop right now because I'm looking at my clock over here, and we only have 10 minutes for questions and answers. So I'm sorry it took longer than I expected, but they cut my presentation with all those introductions of introductions of introductions. So I got just in the middle. So I'm sorry about that. We're ready for questions.
All right, thank you, Dr. Cantuaria, and I will invite Dr. Jones back in to start doing some Q&A. If you have some questions, if you could enter those into the chat box.
Well, thank you, Dr. Cantuaria. You sure did have a lot of information you had to cover, and we certainly can get to these questions. It has generated a lot of questions from the audience. And of course, the Cancer Moonshot program and all of the advances that you have been discussing over the last hour, the goal is to reduce the cancer death rate by 50% in the next 25 years, but it can only be done through clinical trials and clinical research. So one of the questions is, how do you find out more about being able to participate in clinical trials? And do you have to go out of state or somewhere to participate?
So yeah, that's a big problem, isn't it, Cheryl? So to be able to offer clinical trials, one has to have a minimum research department so that you can provide the patient these treatments safely to the patients, and not bias the results, and not have issues of safety and adherence to the clinical trial per se. So to be able to offer clinical trials is a big deal. You know, we physicians, which are principal investigators in clinical trial, we go through training. We have to be aware of all the side effects. We have to have a research department that really helps us provide these clinical trials safely to our patients. And the more farther you get from a metropolitan area, the less likely these institutions are able to have a system to be able to provide the same level of care to the patients. But nonetheless, there are, in the state of Georgia, at least, we have several Commission on Cancer accredited programs. By being Commission on Cancer accredited, they should have a minimum standard of research being offered. And what we do through the Georgia NCORE, with the help of Georgia Core, is really reach out to these other towns and hospital systems throughout the state and invite them to join this network called the Georgia NCORE, where we have NCI trials available to them and help them with the auditing and opening and auditing so that this can be delivered safely in the community. So I think it's critical. Without clinical trials, you can't move forward, period. As simple as that. We'll be in the Stone Ages forever.
And you and I are fortunate enough.
Yes, we definitely are.
Yes,
to be
you
able
and
to
I are
have,
fortunate enough that at the Northside Hospital Cancer Institute, we do have clinical trials, phase 1 through 4, as well as the bone marrow and CAR T program that we have. But anybody can ask their physician, and certainly, you know, can go to the georgiainfo.org for more information. Another question we have is was a lot of interest in your prevention of cancers, that, you know, 42% of cancers might be prevented. And, you know, with changing their lifestyle, with diet, exercise, weight management, and most importantly, tobacco cessation. But there's also a lot of interest in early diagnoses, because the earlier we diagnose something, and screening. Could you comment a little bit on the updates in screening for ovarian cancer, one that we've not had good screening studies in the past, like pap smears for cervical cancer and gynecologists evaluate for uterine and endometrial? What can we do for ovarian cancer in the future?
It's a hidden organ, isn't it? You know, it's deep inside, very difficult to find. CT scans don't see it well. Ultrasound's the best you have. By the time you pick it up on the ultrasound, cat's out of the bag. Different from a mammogram that you can pick up even precancerous states. Ovarian cancer doesn't have a precancerous state. It goes from nothing to cancer. At least the high-grade tumors do. That's the most typical form of ovarian cancer, which is the one that has the fame of being the bad kid on the block. There are many types of ovarian cancer, but I'm talking about the most common, which is the high grade. There's no precancerous state, so we can't pick them up in the precancerous state. So even from a standpoint of screening, what's out there is that you have our screening tests are trying to look at these liquid biopsies are picking up mutations that are developed. And I think that it's challenging even from that standpoint, because we don't have this holy grail for ovarian cancer, not even for looking at the genomic markers that are circulating in the blood. It hasn't worked to pick them early enough. So I think that's going to be a long way to go to get to that point. But by the way, ovarian cancer is not truly ovarian cancer. It's fallopian tube cancer. The fallopian, the pre-cancer stages of ovarian cancer, they start in the fallopian tube, and they jump on very quickly from the fimbriated end, the edges of the fimbriate, onto the ovary, the most typical ovarian cancer, which is high-grade serous. And ovarian cancer obviously gets the blame because that's where they grow and that's where they kind of spread from. So from a prevention standpoint that you just mentioned, is trying to identify the high-risk patients that we would offer then prophylactic surgery, which would be prophylactic removal of the fallopian tubes, at least the fallopian tubes, but standard of care till today is removal of fallopian tubes and ovaries for the high-risk groups that have genetically changed that predispose them to develop ovarian cancer. Having said that, one important thing today that we have changed over the last at least 5 years, probably more, is at the time of your hysterectomy. Today, we remove the fallopian tubes as a preventive measure for developing ovarian cancer in the future. 15 years ago, hysterectomy is hysterectomy. There was no removal of fallopian tubes. Fallopian tubes, we would keep them with the ovaries, kind of not to disturb the blood supply to the ovary so that we have the hormones being produced the right way. But today, we remove the fallopian tubes together with the uterus so that we can hopefully see a trend towards decreasing overall incidence of ovarian cancer in general. We'll know that this only several years from now. But that's the best we have.
Okay. So of course, updating your family history and risk factor to see if you need those genetic tests to help determine if you're high risk is very important.
Mm-hmm.
And that can be through genetic counseling and testing at high centers.
Yeah,
Okay.
that's correct.
Other screening tests in high-risk individuals include if they have genetic abnormalities for pancreatic cancer with a high-risk compatibility program. And there is now screening for lung cancer in
Yep.
individuals who are over the
talk
age
more
of
about
50
that.
and have smoked more than 20. Yeah, so in any individual who's over the age of 50 and has smoked more than 20 pack years, and a pack year is a pack of cigarettes a day, for a year is 20 pack years, should be evaluated for, these are low dose lung CT screening programs. And so that's important to prevention if you do have those high risk. Have some other, we've got so many questions in this chat. We're not going to be able to get to all of them. And I think that the next one is the difference between the genetics and genomics of the cancer. One of the questions to ask, I have cancer and I need to be tested for that gene.
The way I see it, people use these words interchangeably, and it's not just patients, it's doctors, it's national meetings. It's kind of all over the place. So to have a direct definition of what's one, what's the other, what's the difference, I think that's less important than knowing that there are two types of genetic testing. One is germline testing, which is you are going to identify if you are carrying a high-risk gene that predisposes you to developing any cancer or a certain cancer in your lifetime because you inherited that gene from your parents. That's germline testing. And then you have somatic testing, which is looking at the genomic profile, genomic profile of the tumor, and seeing at the tumor level, not the hereditary level. Hereditary level means every single cell of your body carries that gene. When at the tumor levels, we're talking about only the tumor cells have those abnormalities. And that's what we do genomic profiling of the tumor. And we identify targets for targeted agents. Hopefully that made sense.
Thank you. If it's too late to prevent cancer from a healthy lifestyle, once I've developed cancer and finished my treatment, can I improve my outcomes by exercise and diet, or does it not matter at that point?
I think it always matters.
It always matters. And there actually have been studies that have shown that altering your lifestyle after a diagnosis of cancer does improve your survival. And you can certainly learn more about healthy programs through the cancer support community in Atlanta that is sponsoring this program. There's also a question about second opinions. And does Northside Hospital Cancer Institute offer second opinions?
I think what the question shouldn't be like that. I think are we open to second opinions? I think that's the right way to approach that question. I think every single doctor should be. Every single doctor should be very open for patients to go. I regularly, if it's a typical type of cancers, bread and butter stuff, I mean, you can go here, Tokyo, New York City, London, or Brazil. Those cancers will not change, period. You can get 10 opinions, will be the same 10 opinions. But there are certain types of cancers that are rare that doctors commonly lean on each other to get not only formal second opinions, but also informal opinions by phone calls and things like that. And having said that, these cancers, and any case that's controversial, we at Northside Hospital, we have a tumor conference. And that's pretty much not only a second opinion from a single provider, you're getting a second opinion from a number of doctors that are in the same room, evaluating not only the CT scans, the pathology again, the clinical history, the surgery, everything, and it's peer-to-peer. And these tumor conferences are phenomenal ways to share experiences and opinions to come out with a recommendation for that specific patient. And that's a common practice here at Northside Hospital.
So sometimes patients have received second opinions and may not have known it if they were presented in a multidisciplinary tumor conference.
Mm-hmm. Correct.
All right. Well, it looks like we're beyond our 1 o'clock hour, and we're not going to have any more opportunity to address that box. Katie and the cancer support community will forward any that need to be addressed. I'm sorry we couldn't get to everybody's question. It has just been so many today. Sorry for any technical issues we may have had. And
let me just get to one over here. I just opened the chat for the first time because I was just paying attention on the talks, but there's one about psychedelics over here. And specifically treating depression and anxiety. I want to touch base on that because this is something that I personally have spoken to in detail with our psychiatry department. And there's a huge interest of ours of looking into this for treating depression and anxiety in oncology patients. I am quite convinced that that we should pretty much destroy the taboo regarding psychedelics, and that we should revisit this in a very controlled fashion. I'm not saying that everybody should go try some mushrooms out there in the community. I think that's very, very dangerous practice to do. But I think to have this offered in a controlled fashion to cancer patients, like it's done at several reputable institutions, nationally academic institutions, I think it's something that we should consider looking into here at Northside Hospital as a whole. And I'm glad that our psychiatry department thinks the same.
And they can make that reference from going to the Built to Beat Cancer website to learn more about where they may refer people to the psychiatry department if they're interested. Okay. And then Katie, I guess we'll turn it back over to you to make certain we got all the right information for the cancer support community and Georgia Core.
Thank you. Yeah, thank you, Dr. Jones. Thank you, Dr. Cantuaria.
Sponsoring this program.
Yes, thank you both. I know you guys are both repeat presenters for us, and we're so appreciative for always being so generous with your time and expertise. Yes, if anybody wants to connect with Cancer Support Community Atlanta and any of our free oncology programs, I'm going to put our website in again into the chat box. And just a reminder, if anybody wasn't able to make today's live program, you can find a recording on our website under the video tab. So again, I want to thank you both, Dr. Jones, Dr. Cantuaria. Thank you, everybody, for your patience with some of our technical difficulties. And we hope to see you all again soon. Everybody take care.
You too. Thank you. Bye-bye.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org. Or follow us on Facebook. We'll be sharing additional information on upcoming programs.